Okay, there's going to be a lot of repetitions based on the prior talk. I'm going to try to kind of reiterate certain points. I think in medicine we learn by repetition anyway, so that's good. Maybe it will stick on your brain better in this era of a lot of information flowing into through your phones. So this is the kind of case we are talking about. Is a segmental fracture of the tibia. It's not as common, so it's probably about 5% of the tibia shaft fractures. They are usually, as you can imagine, they're associated with severe high-energy injuries. It's hard to break a long bone at two places. Otherwise, it's not a low-energy ground-level fault fractures. So this is the fracture that we are talking about in this group of 42, like middle of the tibia shaft fractures. These are the ones. So the bone is broken at two places. This is different than the C3, so it's not a comminuted fracture at one spot. There's two separate points that you have fractures. So it can be, this fracture lines can be a little proximal or a little distal towards the metaphysis. Then you're going to get a little more trouble about the holding your reduction or the fixation, that you're going to need to use a lot of techniques that Dr. Kretak already mentioned. So there, as I'm going to reiterate again, they are different. They're not only X-ray different, because there's like one fracture versus two fractures, two separate fracture lines, but they are also soft tissue concerns, right? Some of them may come in even like grade 1 type of poke holes, one of the fractures, but a lot of times there may be open fractures. The association of an open fracture with a segmental tibia fracture is pretty high. Obviously, the more open 3B type of ones are more severe soft tissue injury, may have even vascular injuries, and may have more comminution at each fracture site. Two things that I want to reiterate for the sake of this talk. So I think you got to pay attention on these patients, at least in the first 24 hours, sometimes even longer, or post-operatively too, any segmental tibia fractures, because they happen with a high energy injury and associated with the severe soft tissue injury. They're going to be high risk to develop compartment syndrome. And the more comminuted segmental fractures with the fibula too, these are kind of a culprit or the telltale sign to have a compartment syndrome. And in the long term, if you have more than one fracture in the same bone, sometimes one of the fractures heals and the other one may go to non-union, but it's a long-term problem. It's not an acute problem that I'm not going to talk about. Overall, tibia fractures, I think there are different treatment options. On one side, you can cast them if they are minimally displaced or offer casting them. On the other hand, if they are really soft tissue injuries or you are really want to do some kind of circular fixations, you can do that. You can do plating in the metadiaphyseal segments, and basically you can bypass the whole segmental fracture line with a plate. That's possible too. But most commonly, I think you're going to see some kind of intramedullary nailing. And I think you see less and less this flex knee nailing. At least I think all my partners converted already, and most of the centers at the United States don't do much infrapatellar nailing anymore. So I think it's safe to say that in 2025, for tibia shaft fractures, the standard of care is intramedullary nailing. Again, I discuss with the patients if the alignment is good, the casting option, but I think there are a few patients that I have treated with casting, and I usually not recommend it, and I usually sway them for surgery, even they may think about no surgery. I think there's a huge difference of the recovery, obtaining and maintaining the reduction. Again, you can do the surgery in flexion or semi-extended. The flexion is fading away completely, and most people are doing semi-extended approaches for all tibia shaft fractures. This approach can be extra-articular or intra-articular. Most common that I see is suprapatellar approach, as you have seen by Dr. Kretak. I'm with him. I'm always concerned the younger the patient is, putting anything at the patellofemoral joint, unless the patient is a young female with a hyperlaxity, I think you are causing some damage. Again, I'm aware of all the literature that's building up that says that there's no cartilage damage you are putting in there. I still cannot understand that. Again, different types of semi-extended approaches. To fix a tibia shaft fractures, I think you need to have all kind of reduction tools, especially when it's not a middle of the shaft isthmic fracture. You're going to need some of these tools, including the positioning. I think the semi-extended approaches made the life easier for the surgeons, especially the private practice surgeons, community surgeons, who need to do these cases without not much help, without trainers. Again, blocking screws, you heard from Dr. Kretek. I may show a few examples, but he's the king of the blocking screws who described these ones. So percutaneous clamps are very helpful. You may use some kind of ball spike pusher or shank pins, as you see on the fluoro image on the side. I'm going to show you a little more about this traveling traction that Dr. Kretek showed in a few of his slides to you. And fibular stabilization may help your reduction and improve your biomechanical stability too. And in open fractures, I think you should take the opportunity to use some temporary or permanent place through the open wound to hold your reduction, to help yourself to use it. Again, the start side, with every kind of nailing, whatever we do in the long bones, start side is the most important, right? And the more closer the fractures, close to the metaphyseal area or the start side, it becomes more important. And the start side for the tibia is very well described, as shown Dr. Kretek again. What happens if your start side is too medial? If it's too medial, then you end up with this valgus deformity, as you can see on this X-ray. If you are too lateral, can you be too lateral? Yes, you can be too lateral too, and this will cause a translational deformity, actually. So you got to be really careful when you are doing an tibial nailing to get your start side as good as possible. Again, even rotation of the leg may fool you, because rotating the leg 10, 15 degrees may show you that you may be in a good spot or a bad spot. I think you need to get a good AP view of the knee, whichever position you are operating on. Again, this is the typical deformity after a proximal tibia fracture. I show an example here, an exaggerated example. Most often it's not that much, it's usually at 10 degrees or so, but for the sake of showing it. Again, medial start side, this is what happens, valgus. And what happens in the sagittal plane? If your start side is too inferior or too anterior inferior, especially in the knee flexed position, I do still infrapatellar nailing, but in proximal tibia fractures, I recommend that you should not use a flex knee position. You should use a semi-extended position for a proximal tibia fractures, because 99% of the time, you're not going to be happy what you end up at the end of the case when you try to nail this. Despite all the efforts, you're going to lose some of your reduction by the time the nail, the Herzog band goes down. You're going to have some kind of procurvatum deformity commonly. Again, blocking screws are very helpful to line up your proximal segment, but also distal segment too. Again, when it's a segmental fracture, you have to deal with both proximal and distal segment. And it helps for the angular deformity, as you can see, but also the translation of the distal fragment, because the nail is going to go follow the path of resistance, but you can guide the nail where it's going to go with your guide wire and reaming a good path where you want the nail end up, and the blocking screws are very powerful, and you got to plan ahead of time most often. This is an example for a distal tibia fracture. Again, we are putting the percutaneous clamps, holding the reduction, but it seems to be holding, but not great. Then we put another blocking screw, then I think made the life a little easier. It gets our alignment a little better, and by the time we put the nail down, I think the alignment is much better than if we did not have the blocking screw in there. Again, to maintain the reduction, I'm going to reiterate how we get from this to this. You can use hold the leg in, or somebody holding the leg, a lot of radiation going on, and still a lot of struggle, like continuously holding something. I use commonly this traveling traction setup. Almost all of the tibia fractures, although I have trainees, the people can hold it, even in the semi-extended position, in more distal and proximal fractures, I think it's very useful to hold it. And you can see also apply the percutaneous clamps in a segmental fracture. One of the problems about the segmental fractures, the worst thing that can happen, I don't have a perfect example here, but the middle segment, when you are reaming in the isthmic area, and the reamer can basically spin the middle fragment with the reamer caught, and with the friction can spin it. I usually put a percutaneous clamp, something like this, at the middle segment when I'm reaming in a segmental fracture. Again, you can apply also on the right-hand side, you can see that actually you can apply additional pins off to your X-fix to control the segments a little better. Basically, fine-tune your reduction in that way too. The case example we have here, so this is the segmental fracture. I planned this ahead of time for demonstrative purposes. You can apply some pins unicortical, that it's not going to block your trajectory into intermediary application of intermediary nail. The distal fracture is less comminuted. Is it clampable? I thought that we may be. Again, these are all planning. It may or may not work during the case, and you may change your plans or have a plan B. And as you can see, during the case, the clamp distal fragment, and to control the segmental fragment, we are using a pin of a unicortical pin of the X-fix, and we are able to get a pretty good reduction and holding the reduction throughout the case. I think holding your reduction throughout the case is important. And there's one, in the case that I showed earlier, the segmental, but there's a proximal metaphyseal fracture, a very proximal fracture, which is a little harder to control. Again, you can do that with this traveling traction setup and get a good alignment and get them to heal in good alignment. Take-home messages, I think that they are associated with severe soft tissue injury. Again, you are looking at the X-ray, but don't forget the compartment syndrome risk. And it's about the length, alignment, and rotation, right? The middle segment doesn't matter as much as far as your joint line, proximal and distal is fine, and your rotation is good. The fixation is going to be commonly an intermediary nail. Thank you.